Hello everyone, this lecture is going to focus on hypertension pharmacotherapy. The objectives for this lecture are to understand how to assess a patient with hypertension. The most important part of assessment for a patient with hypertension is being able to accurately screen their blood pressure. So we're definitely going to spend a lot of time talking about different do's and don'ts for assessing someone's blood pressure. Then we're going to compare and contrast different pharmacotherapy options for the management of hypertension. I'm sure at this point you guys have spent a lot of time talking about the pharmacology and medicinal chemistry of these agents, but now we're going to talk about where they fall in the guidelines and which agents would be better for some patients versus others. Then we're going to identify potential adverse effects of blood pressure medications. Since medication adherence is so important to controlling high blood pressure. So we want to make sure that we identify, which medications have the highest risk for certain adverse effects and how we manage those. And then lastly, the overarching concept of any pharmacotherapy lecture is to be able to design an appropriate treatment regimen to manage a disease state. So we're looking at the guidelines, looking at pharmacotherapy and non-pharmacologic therapy go hand in hand, especially for hypertension, and then also monitoring, setting appropriate goals, and counseling. Okay, so this slide is just a recap of the pathophysiology of hypertension so that we know what these medications are targeting in the pathophysiologic processes. So we know that there are genetic influences to hypertension because people that have family histories of hypertension are at a higher risk of developing hypertension themselves. And we know that there are environmental factors that can influence blood pressure, like smoking, caffeine, stress, exercise or lack thereof, weight. So a lot of different factors that could influence someone's blood pressure. And all these things ultimately contribute to either an increase in cardiac output or an increase in the total peripheral resistance. And between those two things, an increase in either one or an increase in both of them will ultimately lead to hypertension. So when we talk about pharmacotherapy, we know that it's going to address a lot of these different pathophysiological mechanisms, like the vasoconstriction or the inadequate sodium excretion, which leads to salt and water retention. So again, the guidelines that we use for the management of hypertension are the 2017 ACC/AHA guidelines. For certain special populations, we can also dive deep into their individual guidelines, diabetes and chronic kidney disease guidelines. But for the most part, the ACC/AHA guidelines are very comprehensive and will have goals and treatment options for all patients with hypertension. And there was also a 2021 update to these guidelines too. They made a special statement regarding patients with stage 1 hypertension and that we should start them on therapy a little earlier than previously, but we'll talk about that when we get to the actual slide on when to initiate therapy for patients with hypertension. Alright, so let's start with a diagnosis. So screening patients routinely for blood pressure is critical to identifying when someone has an elevated blood pressure. So if you guys have been for an annual, you know that blood pressure screening is like one of the first things that are done in that office, usually even before the doctor sees you. A nurse is checking your blood pressure. So blood pressure screenings are routine pretty much at any sort of doctor's appointment that you have. A physical exam, as it says there, should include an accurate measurement of blood pressure, and that's really all in technique. And measuring changes in blood pressure from seated to standing positions, this becomes pretty important for patients who have a history of orthostatic hypotension or patients that are older that we know are at a higher risk of orthostatic hypotension. So we'll routinely screen them for that too. And then we're also looking for physical features that suggest secondary hypertension. So if you think back to the pathophysiology lecture and different physical signs that we could see that might mean someone has secondary hypertension. When we take the patient's history, very important to ask for a family history because again there is some sort of genetic component to it. Important to ask for alcohol and smoking history. So If they smoked and they quit, we still want to know around how long ago they quit, just because we take that into account when calculating someone's ASCVD risk. And for smoking and alcohol, obviously, we're going to talk about, how to counsel patients on smoking cessation, or if they are drinking alcohol, what is a appropriate amount of alcohol depending on gender. Then we're going to talk about history that suggests secondary hypertension. So again, looking for potential things that might be causing it if it's not primary hypertension, because if it is secondary, we can identify the root cause and potentially cure them. We want to ask about comorbidities. One, because comorbidities can contribute to hypertension, but two, also because certain comorbidities like heart failure or COPD might change what medications are appropriate for them, or even certain medications that might be better for them compared to other patients without those comorbidities. And then, of course, we want to know what medications they're currently on, because we know that certain medications can increase blood pressure. And then we also want to ask about home blood pressure readings, because sometimes patients could have white coat hypertension, which we'll talk about, and their blood pressures could be a lot higher in office than they are at home. And it's not unreasonable to compare them and make sure that, we're not missing something where we're getting a much higher reading in office and it's not actually an accurate representation of what their blood pressure is. And then obviously labs can provide a lot of information on whether we have target organ damage, or, if there's a secondary cause to hypertension. So we want to take a look at sodium, potassium, look at what their fluid homeostasis is like, look if they have fluid overload. We also want to look at their serum creatinine and BUN, see if there's, any sort of renal damage going on. And we want to look at their thyroid hormone too, because hyperthyroidism can cause, elevations in heart rate and blood pressure too. So just one example of, a secondary cause that we could screen for using labs. So all that is, pretty routine in assessing a patient with potential hypertension. And like I said, the most important thing is getting an accurate measurement of their blood pressure. And something really important for you all to know is that we don't diagnose someone with hypertension based on one reading alone. So we need at least 2 blood pressure readings at 2 separate visits to fully confirm and diagnose someone with hypertension. And we take an average of those 2 readings. So we talk a lot about ASCVD when discussing patients with hypertension. You'll see that it's in the guidelines, and it's also part of their screening to determine what their ASCVD risk is. So what actually is ASCVD? So it stands for atherosclerotic cardiovascular disease, and this includes non-fatal myocardial infarctions, or you might know them as heart attacks. It includes coronary heart disease and strokes. And we estimate ASCVD risk to kind of guide conversations and decisions about different risk lowering interventions. So we use someone's risk for these myocardial infarctions, coronary heart disease, to determine how aggressively we need to treat them. Can we start on non-pharmacologic therapy alone, or do we need to start pharmacotherapy? And the ASCVD risk estimation estimates a patient's 10-year ASCVD risk. So what that's saying is, where the patient's blood pressure is at the moment, their cholesterol is at the moment, their current pharmacotherapy. If we keep all of that the same, what is the risk that a patient will have ASCVD in the next 10 years? And this tool is only used for patients who have not had ASCVD yet. So that's what that bottom sentence is saying. The risk calculator should only be used for primary prevention. So patients who have not had ASCVD yet. And we'll practice calculating this for patients. There's not some, short formula. You just look at their labs, what medications they're currently on, and plug them into, whatever calculator you prefer. But we'll have an example on the next slide. So this is what the American College of Cardiology's ASCVD risk estimator plus looks like. So it takes into account the patient's age, their gender, their race, of course their blood pressure that you have now accurately measured, their cholesterol levels from their most recent labs, whether they have a history of diabetes, of smoking, Are they currently on any hypertension medications? Are they currently on a statin or aspirin therapy? And that includes baby aspirin too. So let's practice using the ASCVD risk estimator plus with a sample patient. Let's say we had a 47-year-old patient who was male, white. His blood pressure was 142/97, and his most recent lab values for his cholesterol are input there. He has no history of diabetes. He is a former smoker who quit sometime between 3.5 to 5 years ago. He's not on any hypertensive medications, he's not on a statin, and he's not on aspirin therapy. So if we plug all those values into the calculator, what we get is that he has a 5.1% 10-year ASCVD risk. So what that means is if everything here stays about the same, his blood pressure stays about the same, cholesterol level about the same, and he continues not to be on any hypertension medication, statin therapy, or aspirin therapy, in the next 10 years, he has a 5.1% risk of having ASCVD. Now, the lifetime risk is also presented here, and it's a 46% risk. Normally, we only focus on the current 10-year risk and try to decrease that by, adding on whatever therapy is indicated for this patient. The optimal ASCVD risk, 1.5%, is, optimally where we would like this patient's risk to be. So let's take about 5 to 10 minutes here to go to the website and mess around, try some of the sample patients from the student guide that I provided, and see what happens when you plug these values in, and then also make changes to what if they were on hypertensive medication, or on a statin, or on aspirin therapy. What if after starting medications, we actually brought their blood pressure down to, 129/79. So go ahead and spend some time on the website. As far as assessment purposes, I won't be asking you to calculate someone's ASCVD risk because you won't have access to this website while taking the assessment, but it's very important to know why we calculate this risk, what it actually means, and which one of these values we look at when we're going to use the guidelines to guide treatment. Alright, so let's talk about blood pressure assessment. So an accurate measurement of blood pressure is essential for diagnosing hypertension and also for assessing how well pharmacotherapy or non-pharmacologic therapy is working for patients once they've started those. So blood pressure readings can vary depending on a lot of things. One of them is the time of day. People's blood pressure is usually lower at night and then is higher in the morning. So, if we're making those 8 a.m. doctor's appointments, even though the doctor probably won't see you till 9 or 10, your blood pressure is still a little higher in the morning than it would be throughout the rest of the day. Stress can definitely increase blood pressure. Acutely for the most part, but if you have chronic stress, that can also lead to long-term elevations in blood pressure. Exercise, it's great for your heart and lowering your blood pressure overall, but if you just ran a mile and then sit down to take your blood pressure, it might be pretty high, higher for some of us more than others, depending on how fit we are. Certain medications, which we talked about in the hypertension patho lecture, can increase blood pressure. And certain foods, are supplements and herbals and drinks, those Monster energy drinks can really cause an increase in your blood pressure. So blood pressure assessment, like we said in an earlier slide, should be based on an average. We don't want to use any one blood pressure to tell someone that they have hypertension or diagnose them with hypertension, because so many things can affect a single value. And then we want it to be an average of at least 2 readings on 2 separate occasions. So just remember 2 and 2. 2 separate readings, 2 separate occasions. Okay, so how do we measure someone's blood pressure? These next couple slides are going to go through technique step by step. I would have loved to be in person so that we could practice in person, but you guys will have plenty of time to practice your excellent blood pressure taking technique during your longitudinal courses. So we're just going to talk about it here, and then you'll be able to apply this later on. So first thing when measuring someone's blood pressure is properly preparing the patient. So you want to make sure that the patient is relaxed, that they are sitting in a chair. You never take someone's blood pressure standing up. You want to keep their feet flat on the floor with their back supported, kind of, sitting upright, not, lean back at a certain angle or anything, just sitting upright, feet flat on the floor for at least 5 minutes before you take their blood pressure. And again, this is because, when we're going from standing to sitting, our blood pressure changes slightly. Or, if they just walked up a ton of stairs to get to the office, we know that that's going to increase their blood pressure. So we want to give the patient time to adjust and get to what their normal baseline blood pressure is before we measure it. We want to tell patients to avoid caffeine, exercise, and smoking for at least 30 minutes before measurement. Obviously, we want to tell them to avoid smoking at all times, but if someone is in the process of quitting or they're not ready to quit, we just want to at least tell them to try to avoid it for 30 minutes before their measurement, because this can affect it. We want to tell the patient that they should have an empty bladder before it. That can also affect the blood pressure a little bit. And then we want to make sure, and this is an important one that some people kind of get lazy with, is that the patient or the observer shouldn't be talking during the measurement. So, a lot of times patients like to make small talk. It's a little awkward when you're sitting there in silence while someone's measuring your blood pressure, but talking during the assessment can actually increase your blood pressure. And then we want to make sure that the patient, if they're not wearing a short sleeve shirt where you can put the cuff where it needs to be, that we're rolling up their sleeves to make sure that we're not measuring over any material, because that's going to create a tighter cuff than if it was just on their skin. So we want to make sure we remove all clothing that's covering the location of measurement. Alright, so using proper techniques. So first we want to make sure we have a device that is calibrated, that we know works well. We have a lot of automatic blood pressure devices now, so you don't have to use, a cuff and a sphygmometer and a stethoscope to get someone's blood pressure like I had to when I was in pharmacy school. We have all these automatic blood pressure tools that work really great and do, most of the work for you. You still have to be able to interpret the values, so we're definitely going to talk about that, but these automatic blood pressure tools are great. We just want to make sure that they're calibrated from time to time, because just like any other, computer, things can fail and start to not read as well over time, so we want to make sure that it's accurate. We want to support the patient's arm, which means it should be resting on a desk or, supported by the armchair. We just want to make sure that it is supported and not, hanging down entirely by their side. We want to position the cuff on their bare upper arm. So again, we want to move up any clothing that is potentially in the way and put it over to the bare upper arm. And we want to make sure it's 1 inch above this bend in the elbow here, and centered directly above the brachial artery. So this is the brachial artery. And we want to make sure that the cuff is centered over it. And, sometimes we'll see observers or providers put it almost right at this crease here, and what happens is it's got a little bend in the cuff. So we want to make sure it's about 1 inch above the bend in the elbow. And again, on the upper arm. And also important is choosing the correct cuff size. If you use a cuff that is too small for someone, say you have a larger patient and you use kind of like the same cuff that you use on everybody else, it's going to measure a little higher than it probably is, because that cuff being tight on them is creating extra pressure. Vice versa, you want to use smaller cuffs if you have a particularly smaller patient, like myself. I'm 4'11" and I weigh about 100 pounds, so sometimes I have to find a smaller cuff to use to check my blood pressure, because using a cuff that is too large, now we don't have enough pressure to accurately measure the blood pressure. So choosing an appropriate cuff size, making sure we're placing it on the right part of the arm, and making sure that the patient's arm is supported throughout the whole measurement are all important techniques for accurately measuring someone's blood pressure. Alright, so that was all on technique. Now we're going to talk about what are the proper measurements that we need for diagnosis and treatment. So we know that we need at least two blood pressure readings at two separate appointments. So at the first visit, if we're assessing someone for the first time ever, brand new patient, we want to take their blood pressure in both arms, and then we're going to use the arm with the highest reading going forward. And this is because, it might vary slightly arm to arm, but we'd rather go with the highest and just err on the side of caution and have a higher average than a lower average, and then potentially miss someone who has hypertension. We want to separate the measurements by at least 1 to 2 minutes, right? I'm sure when you have your blood pressure taken, you feel how uncomfortable that cuff is while it's taking your blood pressure. So you want to give the patient a minute or two to relax and get back to baseline. If we are doing blood pressure the old-fashioned way, with the cuff and the stethoscope, we have to perform the auscultatory determination first. And again, when we get into technique during hands-on applications of this, that will make more sense. So I'm not going to go into detail about it right now, but it's basically finding where to start the pressure cutoff for an individual patient. And we're going to then deflate the cuff slowly, an average of 2 millimeters mercury per second, and then listen for the carotid cough sounds. And the carotid cough sounds we'll get into in the next slide. But that's an image there, of the old-fashioned tool that we use, and you can slowly release the air by slowly kind of pushing on this little circle here. It's the air release valve, so that's what slowly releases air from the cuff that's creating the pressure. So what are these carotid cough sounds? So if we're using the auscultatory technique, we're going to inflate the cuff until we do not hear any sounds. And it varies from patient to patient how high we go up where we start. But after we start deflating the cuff, we're going to listen for that pulsing sound to start again. And that is the first sound, and that is going to be the systolic blood pressure measurement. When the sound stops once again, the disappearance of all the sounds, that is the diastolic blood pressure measurement. And we also want to note if the patient's on blood pressure medications, when their most recent dose was. This is going to tell us, one, if it's potentially lower than it normally is because they just took it, or, if they're non-adherent and their blood pressure is high, that's potentially why. If, they're normally at goal level, but then today they're higher than usual for some reason, maybe they forgot to take their morning dose. So that's why we ask, when their most recent blood pressure medication was taken, to see if that's having some sort of effect on the reading. So here's some examples of the automatic blood pressure devices I was referring to. So, no stethoscope, no sphygmomanometer. It is just a cuff and a device that the cuff is plugged into that will tell you what the reading is. So these are really cool devices that make it a lot easier for patients to assess their own blood pressure at home. Sometimes they'll even have, these types of devices set up, at pharmacies like Publix and Walgreens, so you can just pop in while you're waiting for your medication and take your blood pressure. So, and they're really affordable now too. You can get one of these, from a pharmacy for anywhere between $20 to $40, depending on how nice you want it to be. Some of them will link up to apps via Bluetooth. As you can see, this one has the little Bluetooth symbol on it, and this is a great way for patients to log their blood pressure values over a period of time, see if changes that they've made to their diet are affecting it, see if changes they're making to their exercise regimen are affecting it, and also it keeps all their values organized somewhere so that when they have a follow-up with their provider, they're able to share all these values with them to, help the provider see how well therapy is working for them, see how well non-pharmacologic lifestyle modifications are working for them. the most important thing to note about these automatic blood pressure devices is that all of the other points about technique still apply to using these devices. So you still want to make sure that the patient is seated, feet flat on the floor, that the arm is fully supported, that the cuff is in the right place. And you'll notice, different cuffs will also allow you to maybe put them somewhere else, but the gold standard is still going to be, on the upper arm over the brachial artery. So, talking during the measurement, all of the other technique points that we made when discussing, the old-fashioned way of measuring blood pressure still apply to using these automatic devices. So after we've measured a patient's blood pressure, again, we want to use an average of at least 2 readings obtained on 2 separate occasions to estimate their individual blood pressure. And as pharmacists, all we can do is provide patients the readings and discuss the results. We can't diagnose patients with hypertension. That's not in our scope of practice. Even if you meet this criteria here of at least 2 readings on 2 separate occasions, all we can do is tell the patient, your blood pressure is elevated and you should follow up with your provider, who will then guide you in making any lifestyle modifications or starting you on therapy. After the patient has been, officially diagnosed by a provider, we can go ahead and provide counseling on medications and recommendations for lifestyle modifications as well. And, one of the things about those blood pressure machines being available in so many pharmacies is that patients will measure their blood pressure, and if it's really high, it might startle them and scare them. And, this is an opportunity for us to sit them down and talk about what the numbers actually mean, and also let them know that there's a lot of factors that might be influencing their blood pressure during this one specific reading. So, we can ask them like, oh, you're here at Publix, were you just walking around the store for half an hour doing your grocery shopping, getting stressed out because you're trying to plan a nice meal for your family? Did you just have a whole venti cup of Starbucks coffee before sitting down to take this? So, it's not always cause for alarm, and definitely an opportunity for us to talk to patients and calm them down if they're getting a little unsettled by the level. But most importantly, we cannot diagnose. Just refer them to their provider if they are still concerned and think that they might have elevated blood pressure. Moving on to blood pressure classification, this is the same slide from the hypertension patho lecture that was, green, orange, red from the AHA-ACC guidelines. So we're going to discuss this one more time as it relates to pharmacotherapy, and we'll go into it in a lot more detail. So a normal blood pressure, as in someone who doesn't have elevated or have hypertension, is below 120 for the systolic blood pressure and below 80 for the diastolic. So this is a normal, good blood pressure. And we can have blood pressures a lot lower than that too. Like I mentioned in the other lecture, my blood pressure average, is about 100/60, depending on all the other factors that can influence it in a single reading. But that's what my average usually falls at. So the reason we don't target patients to this normal blood pressure is because when they're at 130 to 139 or above 140, if we were to titrate their medications up or really ramp up the non-pharmacologic strategies to get them to this target, we're going to increase the risk of adverse effects. And studies show that getting them to below that 130 and 80 is beneficial enough when it comes to reducing their risk for cardiovascular morbidity and mortality. So I just wanted to add that note here of, if this is a normal blood pressure, why don't we use that as the target blood pressure? So, elevated blood pressure is between 120 to 129 for systolic and below 80 for diastolic. And again, for normal and elevated, we have and here. So we need to make sure that both of the levels, the systolic and the diastolic, are below these target ranges. Now, if we have hypertension, we divide that into stage 1 and stage 2, where stage 1 is between 130 and 139, or their diastolic is between 80 to 89. And for stage 2, we have anything above or equal to 140 and anything above or equal to 90 for the diastolic. Now, we do have this phenomenon sometimes in certain patients called white coat hypertension. And it basically means there's an elevated blood pressure in a doctor's office, but then we compare this to their home readings and they have normal blood pressures. So this is usually caused by the anxiety of being in a doctor's office. Some people have nerves about going into a doctor. They might have a certain history with, consistently getting bad news in a doctor's office, or maybe they have a parent that, passed away, unfortunately, from a cardiovascular disease. There's all sorts of reasons why someone could have, bad feelings associated with going to the doctor's office. Their health insurance might be another one. Maybe they're expecting to get a big bill after this visit, so it's not easy for people to go to a doctor's office all the time. And about 5% of people that have white coat hypertension get a hypertension diagnosis. And this 5% is not good. So we don't want to inaccurately diagnose someone with hypertension if it's actually just an acute elevation in their blood pressure during this doctor's office visit. So what you can do for these patients is help them find ways to be more relaxed. So, tell them to try to find a doctor that puts them at ease, that they have a good relationship with. As someone who is in the healthcare field, and then also, I've recently been on the other side of it and dealing with a lot of healthcare professionals while my daughter has been in the NICU, and I can tell you that, bedside manner really fluctuates from provider to provider. Some people are going to be really empathetic and really able to communicate with you and put you at ease, and some people are going to be just by the book and very kind of cold and standoffish. Doesn't mean either one of them is a better provider, but definitely seek out someone that you have a good relationship with. And then also patients that are nervous about diagnoses or missing information or getting flustered with the overwhelming amount of information that they're provided with, or they're concerned that they have all these questions in mind and they might forget to ask them, recommend that they bring a list with them so that they're not anxious about, I'm going to forget to ask about this, or I'm not going to remember what the doctor told me. Tell them to bring a pen and paper with them so that they can take notes. And then also make sure you tell them to allow extra time to get to their appointments so they're not stressed about getting there late. And, as we said earlier, for patients that do smoke, tell them not to smoke before the appointment. Not only can that, change their blood pressure, smoking can also just, make you a little anxious. So can drinking coffee and exercising half an hour before the appointment. So all those things we want to avoid about 30 minutes before an appointment. So this image here, hopefully you'll remember, cure for white coat hypertension is just finding a way to make the patient a little bit more relaxed. Alright, so as I've mentioned, the blood pressure goal for most patients is going to be below 130/80. Again, for most patients. We will talk about some special populations where we might have a slightly stricter blood pressure or a slightly looser blood pressure goal. But the reason that most patients we will target to this below 130/80 is that studies have shown that targeting to this blood pressure goal can reduce morbidity and mortality from cardiovascular events, and it can help reduce kidney disease also, because we know that one of the pathophysiologic mechanisms of high blood pressure is that fluid overload. So not only can that cause high blood pressure, but we know that it can contribute to kidney disease as well. So targeting patients to this blood pressure goal of less than 130/80 is what's going to work effectively to reduce morbidity and mortality from CV events and kidney disease. And we want to make sure that we are targeting blood pressure to this specific blood pressure goal, right? So when we start medications or recommend non-pharmacologic strategies, we're going to consistently monitor the patients to see how well they're doing of reaching this goal of less than 130/80. So it's a very concrete measurement, right? Whereas sometimes in other disease states, say GERD, for example, and we start a patient on, antacids to lower those symptoms, there's nothing objective that we're really measuring to make sure that those medications are working for them. But blood pressure, like some other chronic disease states, is a disease state where we very consistently measure an objective lab value or screening tool value 130/80 to make sure that they're getting to that goal. And we choose drug therapy based on the evidence of reducing morbidity and mortality, not just a reduction in blood pressure, though. And what that means is, yes, we are, treating all these patients to target to this goal, but if patients have comorbidities like heart failure or chronic kidney disease or diabetes, we also take that into consideration when choosing the best medication that's going to reduce their individual morbidity and mortality with all their comorbidities in mind and get them to that targeted blood pressure goal. Okay, this slide was also in the patho lecture, but I'm just going to re-emphasize here one point about this slide is that patients may not have symptoms. Since we're talking about pharmacotherapy now, we often talk about clinical presentation in these lectures, but a lot of times patients with high blood pressure, especially in the earlier stages where we don't have any, end organ damage or disruption yet, patients don't typically have symptoms. But we can see some of these end organ issues start to show signs of some sort of damage a little earlier on. Sometimes patients can have headaches, they can have some chest pain, they can notice some alterations in their kidney function or sexual function. So sometimes we do see some symptoms as the disease progresses, but normally we don't see symptoms in these patients, which again is why high blood pressure is known as a silent killer.